Okay. Hello, everybody. If you have ever had a question about running and prolapse, then you are in the right place right now. I am so excited. I've received this question so many times recently, and I think it's amazing because I happen to have someone on the show right now who is actually truly a luminary in the field of women's health physical therapy, and I know she'll blush at that, but it's true. Julie Wiebe is a physical therapist who has been in the women's health and the sports medicine world of physical therapy for 20 years. Is that right, Julie? 20 years.
It's actually 21 this week.
21 years. That's
easy. Yeah,
that's wonderful.
I know.
Time flies, but I mean,
yes.
Huge amounts of clinical experience. She still maintains a clinical practice in Los Angeles and is also a sought-after speaker and has several online courses and DVDs that you'll want to check out. So what we're going to do, again, is talk about Julie's concept of the pelvic floor piston. We're going to talk about specifically prolapse and pelvic floor dysfunction, other forms of pelvic floor dysfunction, maybe incontinence, that kind of stuff, and running, because that's a very big question for people. And before we get into that, though, I'd love for Julie, just if you can tell us a little bit about how you got into, the field that you're in right now and a little bit about your personal journey.
Well, thank you for having me. It's kind of you to invite me to come on. I kind of fell into this the way that most people fall into the pelvic health, women's health arena, and that's after I had my first child, and which is everybody, right? But I was an orthopedic sports medicine PT, and I still really identify as a sports medicine PT, but I sort of had my first right when the core was becoming a thing. Like I have been around for a long time. There used to not be a core. Like people don't realize that used to not exist. But when that started coming out, we started understanding more about that. I realized that after my first, I kind of lost connection with the components of that system that we were now learning about. And the pelvic floor is a part of that system. So I thought I needed to understand that better. So I started really investigating all that. And anyway, one thing led to another. And I wanted to be fit again after my pregnancies. I was working in the sports medicine orthopedic clinic. Most people that come into those clinics want to be doing their fitness at whatever level it is. And so it really kind of moved me in the direction of trying to blend those specialties. And so that's really where I've been kind of just working it out for years. But always more from a perspective as a sports medicine therapist. I don't actually do classic women's health. I'm not an internal PT. So just so everyone knows that. So my perspective is always sports medicine, always kind of working from that literature and that understanding of how we train people, because I want to apply that into the women's health condition. So that's kind of where I've been, and how I got where I am. So I kind of got into this backwards.
Yeah, no, I love that. And can I ask you, are you an athlete yourself? Do you have a sports background?
I'm an aging athlete. Yeah, I mean, I played soccer all the way to college, and then even after I graduated, like masters leagues and things like that. So I like to stay fit now. I mean, my fitness has changed over the years, and just different changes in terms of what I enjoy. But yeah, I love sports.
Yeah.
Love. Yeah. Like I am that crazy mom on the sideline of my kids' sports. Like I want to get out there with them. Yeah. So this is a female athlete sitting here, and really an aging one, but I got that heart. So
that's great. Yeah. So what made you kind of come up with the pelvic floor piston, and can you tell us a little bit more about that?
Well, it's really based in the research. So it's just the terminology that I coined around the movement that the research told us about. And that movement is the interaction between the diaphragm and the pelvic floor and the abdominal wall. And basically, it's when we take a breath, the diaphragm comes down, the tummy and the pelvic floor are supposed to open and give. My hands are moving out of screen, I think. So I'll go up here. So when you inhale, maybe I'll back up. Yeah. Mm-hmm. Inhale, the diaphragm comes down, the pelvic floor lowers, and the tummy opens. So it's sort of this pistoning action down. And then on exhale, when the diaphragm lifts, those guys sort of recoil back up. So it looks like a piston, which some people don't necessarily resonate with, but that's what pistons do in your car. They go up and down. But that is just what the research tells us that the action is. So I didn't come up with the action. The design is God's. Yeah. I just learned about it from the research and then applied it into this population because that action, and if we're going to talk about running, what that's doing is putting the pelvic floor through its range of motion. Okay, so when you think about like your bicep goes through a range of motion in order to be healthy. Like if we kept our muscle like this all the time, it wouldn't be healthy. And so that sort of idea was sort of a kind of to use your pelvic floor in a way that let it go through its excursions, to allow it to relax and contract, to use it in that way I didn't think of it as, anyway, it just sort of was a new way of looking at things related to the pelvic floor. And so it's really, and that really applies when we start talking about running, because you need the pelvic floor to go through excursion to reduce impact.
Yeah, and what I was just thinking of there is I think a lot of people their initial thought, if they have, let's say, prolapse and everything's feeling like it's falling out, or they have bladder leakage, or they have some kind of thing going on, they might feel like the best thing for them to do would be to contract and hold a Kegel, a contraction, the whole run. So we're talking maybe a 5-mile run or a 20-mile run or a half a mile run, whatever it may be. So my question for you now, I know the answer, but go ahead and explain to us maybe if that's a good idea, and if not, then what you should do instead.
Yeah. Well, I think before I answer, I have to plug my computer in.
Oh, sure.
Excuse me. But I can talk and plug.
Talk and plug. That works.
Talk and plug.
This is real time, people.
This is real time, people. Sorry about this. So the way that I like to try to explain it to folks is that if you thought about gripping your glute or gripping your quad the whole time you were running, it would interrupt your ability to run. And so because we don't think of the pelvic floor as something that goes through a range of motion, and we don't think of it as this supple tissue, and we kind of have set it aside as something different than the rest of the muscles in our body, we've somehow gotten to that as one of our solutions, that we just hold it. But we would never do that with any other muscle when we were going through a dynamic activity. So it's not a good idea to do that because that's not really how it functions. And I think it's important for people to understand that even, and likely people who are listening will resonate with this, even if you are gripping, you still leak. Like that's why a lot of people do that, right? Or we're talking more about prolapse, but a lot of people with prolapse leak, some don't. Yeah. There's a component of that feels protective, but unfortunately, a lot of those people still have the same problems after. And the reason is that we've always approached pelvic health stuff as just pelvic floor problems. But if we understand that it's linked in its function with the diaphragm, with the abdominal wall, and that cycling system, then we understand that whole system plays into anything that's going on with the pelvic floor. So when I talk about prolapse with people, a lot of our solutions, and this is important to understand for running, a lot of our solutions are pelvic floor related. Like, let's strengthen your pelvic floor under the prolapse. But what I tell my patients is if you have a house and you're building the foundation, it doesn't matter how strong the foundation is if the roof is crashing in. Oh. And what ends up happening for a lot of our women who have prolapse, they can strengthen the heck out of their pelvic floors, but they still are symptomatic, or they can't really ever get beyond a certain point because they don't manage the roof. And what the roof is pressure. And when we do that pistoning action, what's happening there is the diaphragm is creating pressure that the pelvic floor is responding to go down. And it sounds scary if you have prolapse, but it's natural. Like, that's what's supposed to happen, and we're supposed to use it in a way that's positive. But when women breathe, that pressure increases, and we get that pelvic floor down. On exhale, the pressure goes away, and the pelvic floor rises back up. So when I talk to my patients about that, and I help them learn that we need to manage that pressure and work on the pelvic floor underneath. So with something like running, what a lot of women do when they grip their pelvic floor is they usually grip their tummy too. and they actually end up with a lot of really shallow breathing. And some women will actually hold their breath while they're running until they gasp. And then they hold their breath until they gasp again. And all of that is pressure down. Tummies clenched, breath holding from above, or shallow breathing from above. All of that directs pressure down. And sometimes it doesn't matter how strong your pelvic floor is. You can't keep up. Like the pelvic floor can be overwhelmed.
Yeah, that makes
does that make sense?
Yeah, absolutely. And also, I sometimes refer to it as, this is a bit of a misnomer because I call it Hulk vagina, which I realize we're talking about the pelvic floor muscles, not necessarily the vaginal canal. But I think that people might get a sense for that. Yeah, get a sense for that feeling of when those muscles are overly tense and overly tight. They're not necessarily strong and functional. So they may be rigid, but they're not strong. They're rigid, but they're not strong. And so, of course, what you're saying to me is that, and to us, is that if you have this downward pressure from your diaphragm on this rigid, but not really doing its job, tight pelvic floor muscle that's clenched, but not really that strong, then that's just going to potentially make the prolapse actually worse than if you would allow that piston-like motion to happen.
Right.
So, okay, so, yeah.
Well, and then just to kind of riff off of that thought is that when we learn to allow that to happen, we're teaching the body to manage pressure again. Yeah. Like when we let the pelvic floor learn to respond to that again, at least that's theoretically what I hope is happening, is that we're learning to manage and use pressure positively again, rather than it be our foe, right? Like, let's let it be a friend again versus a foe. So it's really, and then that ability to go up and down is how we absorb impact. So when we run, your knee bends and straightens. And that's how we absorb impact, is by bending. It's like a spring, right? And it absorbs that energy of your foot hitting the ground. And then it springs back up. Well, that's what's happening with the pelvic floor with every breath, but it goes through that same kind of excursion. I don't know if that's the right word that makes sense, but that means it goes through a range of motion at every impact.
Yeah.
And so we got to teach it to do that again in order to be prepared for running. So that's sort of the background of where I start with my folks who want to run and who have a history of pelvic health stuff.
So what would you tell somebody who is maybe they're recently diagnosed with prolapse, they recently discovered they have it, they're really symptomatic, and they're scared to start running again? What would you tell them? They're maybe scared or anxious, they're just feeling some trepidation about the whole situation. Sort of how would they get started? Would you tell them to substitute an alternate activity? Go for it.
Well, the answer there has to be it depends, because people are at different stages of rehab, different stages of recovery, different stages of prolapse, right? So, and there is a lot of fear around prolapse, which I totally understand. It's very scary. I had some symptomatic prolapse symptoms after my second, and so I get it. I know what it feels like, but I think that, so what's important is that we also, understand what staging means and how, anyway, that's probably beyond the conversation here. So let me just stay a little more focused. But I think what I would want to do is first teach people to utilize their pressure better, to be able to walk without symptoms. Okay. Like, you know what I mean? Like, you got to kind of build back up, and then ultimately over time start to do things like intervals. To do a 30-second run and then a walk, and then a 30-second run and then a walk. But where that's a leap in a lot of cases. So I love hiking. I love to have people hike up a steep hill, because that actually sort of optimizes putting this system in its best environment to work well. It can work well in other positions too, but it sort of does its best and can be reconnected really nicely in more of a rib cage over pelvis position. And hiking up a hill does that really beautifully, and it can be intense. You can go steep. You can get that rush of intensity by hiking and you're reducing the impact. Because when we talk about all this stuff about pressure from above, we're also with running talking about impact from below. So it's kind of a double whammy on people who want to do impact activities. So hiking is one of my favorites, treadmill walking up an incline, things like that can sort of, and then you just slowly build your speed until you get into a light jog. So that's sort of an incremental if we were ready to start running. And really there's some, you gotta start working on these pieces a little bit before you're ready to just go back out and run. And I would recommend, I don't do internals. If I think someone's symptomatic of prolapse, I try to get them to see someone who has the capacity to investigate what's going on internally. I often get women who have already been to see internal therapists who want to get back into athletics. And then the other thing with running that I found the most important thing is rotation. So if you're, when you're running, have someone watch you, videotape it, watch yourself run. And if you see when you run that you're only turning here, like through the shoulders, then you're not really turning through here. And when you run, you should run. You don't want to look like this.
Yeah.
Okay? Chest up, boobs up. You know what I mean? We want to be really super athletic. Like this is what we want it to look like. And when I'm doing this, I can't grip my abs. Mm-hmm. Part of why women look like this is they're gripping their abs because they think they should. Sorry, my face is out of frame, but I want you to see my face.
Yeah, no, it makes sense.
But so if you're gripping your abs while you're running, you are potentially pushing down. That's a lot of force down as you're running like this. So if you're really gripping, but if you want to rotate, then you're going to lose the ability to grip. So if you could even try that. Like if everybody squeezes their tummy right now and then tries to rotate, it's very upper body.
Yeah.
But if you relax your tummy, you can actually rotate. And then I have found for women who want to run that have any history, pelvic health at all, but prolapse in particular, I just try to get them to work towards that nice rotation. So we do a lot of prep. This is not day one with me. We're working towards as much rotation into your program as we can to knock out your capacity to grip your abs, because that's one of the biggest enemies for prolapse.
Because the gripping of the abs, like you said, tends to lead to a holding of the breath, correct? And shallow chest breathing up here.
More the shallow chest breathing, but breath holding is a substitute pattern for a lot of postpartum women, and I think part of it's just they're not the appropriate pattern for this activity. We need this activity, meaning running, is dynamic. It's ever changing, and you're doing something on the opposite sides of the body every step. Yeah. You have to be doing something different on both sides of the body. So if we're gripping our abs, we're doing the same thing on two sides of the body. So we think we're stable, but unfortunately that's not actually the stability we need for that activity. Does that make sense?
Absolutely. I get what you're saying now completely. So for example, if you're doing a Pilates mat class, you're going to want to be stable and strong through the core and the abs. You're going to want to engage the core appropriately per your instructor's instructions. But for running, which is a more dynamic activity, that's not a time to be engaging your core in that particular way like you might do in a mat Pilates class or that kind of thing. Am I getting that right? Okay.
Yes.
Okay.
Yeah. So you need you need the system to be task appropriate. So whatever the demand is, and in this case we're talking about running, you need to make sure that the way that you're using your body matches the demand. And so that's really important, and it's very different than how we've sort of thought about things, because people think the only way to be strong is to be stiff and to be really sturdy. Yeah. But the reality is, if you think about how that system looks, that pressure exchange, that movement, stability is actually kind of dynamic. Yeah. It's not stiff and static. It's very fluid. We've sort of turned alignment and posture and core strengthening into this very stiff, static I got to hold myself like this all the time. And the reality is it's very fluid and dynamic. Like, it's not intended to be so stiff. We don't have to work that hard to stand up against gravity, or we shouldn't. And then when we translate that into our exercise, we go overboard. Then we really ramp it up. And then that's really where a lot of women with prolapse in particular, and other kinds of pelvic health issues that have pressure as a component, which means incontinence too, and diastasis, we ramp it up. Like, we ramp up that pressure and that force inadvertently, and then that's a piece of the puzzle. Yeah. So usually I'm working on balancing all of those components for my patients versus that they need any additional strengthening. Mm-hmm. So it's more like, can I show this? This is my handy dandy balloon. Can you see it?
Yeah, that's perfect. Uh-huh.
So diaphragm, abs, pelvic floor. Mm-hmm. So just to give you an idea, like, if I'm holding my abs all the time, and that's my go-to, I'm making a choice on how that pressure is being changed around in my body. Yeah. Right. So there's lots to be learned from the balloon. I won't go into it too much more, but I think that we just need to start thinking about. So let me just say this. So it isn't necessarily that this is so weak. It's that we sometimes need to learn to get rid of this. Yeah. Right? Like, to balance those forces versus that this is so weak. Like, that's the word that women hear a lot is, oh, I must be so weak. But the reality is you're probably just not coordinated. Not you. No, like, you're not. Yeah. But system. That system's not coordinated well. So anyway.
That makes sense.
Hopefully it's making sense.
No, it really is. So, I mean, it is all about balance. This is not saying, please correct me if I'm wrong from your perspective, but this is not saying throw the baby out with the bathwater, no more core strengthening, don't ever do your core strengthening exercises. It's more, do your core strengthening exercises as works for you, but don't be holding those muscles in all day long. Be careful that you're not overworking the core, and, really balance. It's a fluid system. It's all about relaxation and contraction and just the body working as it's meant to work naturally. Is that...
Yes.
Okay.
And really the goal is automaticity, meaning it should just be automatic. Yeah. Like, you didn't used to have to think about this, right? Like, and our kids don't. So it's really intended to be a brain strategy. Uh-huh. So once you kind of reconnect and reestablish that, your brain likes it. Uh-huh. Like, the brain will take over and you don't have to think about it so much anymore. That's the goal. Like, when I give all these strategies out to my clients, the goal isn't that they're going to have to concentrate on their breath every time they take a breath for the rest of their life. Like, I like to trigger core work, and, I use the word core lightly because it means different things to different people, but I like to trigger it through breathing related to your exercising. And, when you're exercising and you're being challenged, then you might want to give it some extra attention. But if you're standing in a grocery line, you shouldn't have to like once you've trained the system, you're gonna need to really tap into it when you challenge it even more. Yes. You know what I mean? Yeah. It used to be standing in the grocery line was enough to trigger a symptom. But then once you've created a neuromuscular, that's a big word for, that coordinated action, it's going to be okay here. It's going to take a lot more challenge for you to actually need to access it consciously again. Do you know what I mean? And so a lot of people keep ramping it up, but the reality is eventually it gets trained. Mm-hmm. And then you don't, like, a 1 pound weight doesn't feel heavy anymore when you've been working out. You need to keep ramping up your challenge to access it in that same way. Does that make sense, or am I kind of muddying the water?
No, I think it does make sense. Yeah, for sure. So I'm wondering, with all this talk about the breath, is there a simple kind of take-home tip? Because you gave people a great tip about kind of slowly progressing the running by, walking with this sense of the piston, pelvic floor piston, kind of walking with that sense, and then adding some intervals, and then also hiking uphill is a great substitute as well. Yeah. And then maybe working into running. But how about breathing? Is there something they can do at home to get started that would help?
Yeah. Can I just say one thing about running? Yeah. When you do, like, that whole progression is if you have symptoms, you need to back off. Yeah. Like, just hear me. Okay. Like, I don't want people to be like, well, Julie Wiebe said that we could just start running. Like, you need to listen to your symptoms, and you need to stay below your threshold, like your symptom threshold.
I have a thought there. I used to tell people in clinic that whatever you think you should do half of that. So if you think, well, I ran 5Ks, so I should be able to go out for a 20-minute run. do half of that or less than half of that.
Great.
Like
right.
Yeah. Okay.
That's great advice. Okay. Yeah. And I get the female athlete mindset of like, well, my pregnancy was fine. I'm good. Like, I'm just going to start running again. Like, I get it, but you just need to recover this system, reestablish it. Then you gradually build on that. Like, just be careful. That's all. Yeah. Just be careful. But anyway, sorry. And then the other question, breathing. So just basically, I think what's important is to understand that we're looking for you to be able to move your rib cage like an umbrella. Like, I'll just totally simplify that. It doesn't mean you can't ever breathe into your chest again or simply into your belly, but this is a little different than a diaphragmatic breath or just a belly breath. This is really a balanced breath, okay? And so what we're looking for is for the rib cage to kind of open all the way around like an umbrella. So you're opening the sides, the front, and the back. Sometimes I cue my patients, it's a 360-degree breath. A lot of them don't know how to breathe to the back, but you're trying to open all the way around. But in order to do that, you're going to need to relax your tummy. Like, you can't, if you're still gripping your tummy right now because you think you're supposed to, you should, as you just said, then you're not going to be able to do it. So you can, so that's really kind of where we want people to go. And then also to understand that your pelvic floor needs to give a little bit when you inhale. And so when you inhale, if you just sort of learn to relax the bottom of the system, it doesn't mean that you're in that. For someone who has prolapse, that's a little scary. Like, it sounds scary, but there's a difference between bearing down and holding your breath and the pelvic floor going down and breathing and allowing the pelvic floor to have some give. And so that is sort of a place to begin. And I find that most people do a nice job with that breath when they've got their rib cage sort of over top of their pelvis. That actually helps to optimize that breathing pattern. And again, it just helps you find it. And it doesn't mean you have to be in this perfect position. Please don't misunderstand, because we need to be careful about that too. But that's a place to reconnect with it, is when you kind of get yourself a little bit over top of your pelvis, like just being, instead of being here, just sort of live here. I like to lean from the ankles forward and play with how your breathing feels. When you're kind of here, feel where your breath is. And if it's up towards your ears, that's not an optimal pattern. But if you just lean in a little bit and try again, you'll find that it lowers and your belly will rise a little bit. So just play with that a little bit. But it's sort of, I like to call it an umbrella breath. And then and it allows you to, if you relax, it allows for that recoil on the exhale. So you got to get a good inhale to take advantage of that exhale. And P.S., this is for the prolapse, women with prolapse out there that are listening, that feels fearful to let your pelvic floor out, is that we need to understand that is a stable position, okay? Like, inhale and the pelvic floor lower, we have to understand that that's a balance of pressure and muscular force. When you hit it well, like that idea of the Hulk vagina, or I would say pelvic floor, vagina, but when we allow, remember, inhale, there's an increase in pressure, the pelvic floor comes down. That's a counterbalance, so that it's perfectly coordinated. And the stability that we get in that moment is in part because of the pressure. Pressure is part of our stability. And so that's why when you have to push a refrigerator off a child, you hold your breath and grunt and push and make it happen, because we use pressure to create a lot of strength in the center. That's what CrossFitters are doing when they get into their max loads. Pressure is a part of our stability. So we have to understand that just because you're inhaling and the pelvic floor is down, it is also stable. We've made exhale and contraction the only time you're stable, but that's actually not true. You're stable on both ends of that breath cycle. And I think that's brilliant. The design is brilliant. Like, it allows, because you're not going to always get challenged on exhale in life. Yeah. When you step, when you're walking, when you're running, this is really important for my runners. I train them to take impact eventually on both inhale and exhale, because when they're running, they will inhale at some point when they land a heel. Yeah. So you have to start to really kind of rethink I'm only stable if I'm breathing out. I'm only stable if I'm contracting my core. The reality is it's really a balance between those two factors, and inhale is stable too. I know it's crazy, but it's true. Okay. We just have to find our way to that balance again. So anyway, so sorry, that was a long-winded answer to how to breathe.
No, I think that's great. I think if someone were looking for like a home exercise program, if you will, and we're not providing medical advice, like this is see your physical therapist, see your provider. But if someone were to look for a few simple things they could do, I think one thing perhaps could be maybe 2 to 3 minutes of really focusing on that umbrella breath pattern and just feeling into the body and increasing body awareness. That's one thing that I am trying to constantly tell people is you need to learn your body, because especially me on YouTube, like I don't know what your, like you said, your stage of your level of healing. I don't know. Everyone's so different. Right. But if you get to know your body, you'll know what is too much for you and that kind of thing. So maybe just a period of time doing the umbrella breath, and then, as you said, possibly working into the running slowly. I think that's simple. And understand that your emotion is part of it. Like when I tell you that I train my women with prolapse and incontinence to take impact on inhale, I don't start like that. No.
We just be clear. Yeah. Okay. That we start with always an exhalation before any challenge. We start there to build the system, to get you reconnected. But then if you really have a goal that includes anything that would require you to be challenged on inhale, my job is to help you get there. And so we have to move towards that when you're ready. But exactly what you just said, if you get symptoms when you do it, you're not quite ready. Yeah. Like you just have to listen. But the breathing is a big one. But the other thing is to stop holding your breath. Yeah. Like if I could tell pressure, you're increasing the pressure against your prolapse. And so if I could give anybody with prolapse advice, it would be to try to do this inhale, exhale. I call it blow before you go. And the idea there is that the exhale, because we know that it triggers that recoil, if you start the exhale before you move, you've triggered the recoil support and then the challenge is sort of already met. Does that make sense? Yeah. And it's being done naturally by your brain versus you over recruiting and doing the Hulk vagina, right? Yeah. So it's sort of this, in my mind, that's an attempt towards making it more automatic, building it into your function, building into your brain strategies that you blow before you start to move, then you know you're blowing off all the pressure. You're getting rid of your pressure before you get out of a chair. You're getting rid of your pressure before you lift your baby. And so I call it blow before you go. Get that exhale started and continue it through the challenge as you start to get into out of a chair or whatever, because breath holding is probably one of the worst stability strategies we have if you have prolapse. Yeah. Sorry, let me restate that. If you're using it for a low load, okay, meaning you shouldn't have to hold your breath to pick up your baby. You really shouldn't. Yeah. And so, or a pencil, or open a car door. Like when you walk away today from this podcast, you will probably think, oh my gosh, I breath hold all the time. And so that's knowledge is power, people. As soon as you recognize it, then start blowing before you move. It's a really simple strategy. And that good inhale of an umbrella and exhale together is just a nice way of starting to integrate that pistoning idea into your function. Because fitness isn't the only place to train it.
Yeah, it's like the idea of muscle memory that I think a lot of people have heard that term, muscle memory, right?
Yeah, absolutely. And then you don't have to think about it. Because sometimes the baby's going to be screaming, someone's going to be honking behind you. You can't do it consciously. The goal is that you build that brain strategy so it's there when you can't think about it. That's the goal.
That's perfect. Oh, I think this is great. I think that's a great place to wrap things up. It's given people a lot to think about when it comes to prolapse and running, all of that. So thank you, Julie, so
You're
much.
Welcome. Thank you. Yeah. Thank you for having me.
Oh, you're welcome. I'm going to put all of Julie's links in the video description below, the notes below, so we'll get those after the show about how people can connect with you. But is there anything you'd like to leave folks with, maybe how they... Anything you're working on or?
I'm hoping to work on I'm hoping to put out a diastasis and a prolapse program for women. I do have some online stuff specifically for individuals, but it is applicable already to if you have a prolapse or diastasis. It's the same system that supports those issues, but those programs are actually, I'm going to hone it in a little bit more on diastasis and prolapse, hopefully by the summer. That's my goal. Nice. So that's coming.
Great. Yay. Well, like I said, I'll put links in the notes below. So thank you again. And I guess we'll sign off. So see you guys later. Bye, Julie.